Hello. Good afternoon, everyone. This is Dr. Nu, one of the Plab 2 mentors, running this session today just to help you find out how Plab 2 happens, what are the different important things that you need to know about Plab 2. I understand that I want to keep everyone their mics closed at the moment because this meeting is being recorded, and we'll just keep it there so that other new candidates who are in for Plab 2 information, they can then later on go through this recording. So I hope that that's all clear. We will start the detailed discussion about Plab 2 just in a minute. Before that, let me just tell you that I run a few courses, including a revision course. A detailed course is just in progress. Some workshops, including your Simon and your examination workshops, to conduct online mocks as well. Keeping in mind that all these different services which are being provided, they are being provided for Plab 2 candidates. If you require any information, just feel free to drop me a message. You've got the email down there. You've got the link to the Telegram group, and there's a Facebook group as well. With Plab Guide by Dr. Nu. You feel free to join. Any questions about Plab 2 and or about the courses or about questions, just feel free to ask. I'm always there to help and assist all the Plab 2 candidates. So let's start with our meeting today. This is for those candidates who have recently passed their Plab 1. If we go back a little bit, your journey to work in the UK starts with your OET exam, which is an English exam where you show your capability that you have all the 4 capabilities of being able to read, listen, and write and communicate in English very, very well. That is when you are able to sit for Plab 1, and then you're tested for your knowledge about the different diseases, different problems, different issues, ethical, non-ethical. And once you are deemed competent, then you are able to sit in your Plab 2 exam. Why was it so important for me to talk about all this? Because many candidates, they think that Plab 2 is more of an English exam. Our English capabilities are being assessed along with the Plab 1 knowledge that we have. So please keep that in mind. It is not so. Your English has already been assessed, and this is not an English exam at all. This is an exam where your capability to communicate with the patients, either that is for counseling, or that is an ethical issue, and or that is a medical problem, or that is just a question that your patient has, your communication skills are being tested at all times. That is why interpersonal skills, how you communicate with a person, is very, very important. So just keep in your mind that this exam is not an English exam. Definitely, it needs to be in English. It is conducted in English, but it is not basically an English exam. If you've already passed your English exam, if you've already done your applied knowledge test, the AKT, it means that you are competent enough to be able to speak enough English to communicate with the patients, because you've already been tested on that. So please do not doubt your Englishes if you have already done your OET and Plab 1, and now it's your time to sit in your Plab 2. My very strong advice would be to practice your Plab 2 exam from the very beginning only with English-speaking doctors, English-speaking colleagues. If you are speaking in your own languages, like, for example, Hindi, Urdu, Arabic, Spanish, Persian, it will be less useful for you. It's very important that try to only join those groups where you are able to listen and practice in English, because this exam is being conducted in English. Many candidates, they tend to suffer when they practice in their own languages, and then they are trying to go in and do the exam in English. So just be careful about that. I do not want you guys to suffer in the end. So if you are starting your Plab 2 journey now, today, or you just recently started, start it in the right direction. All right. So what is Plab 2 exam? It's a professional and linguistic assessment board test that is conducted by by the UK, the GMC, which is basically the General Medical Council in the UK, which tests you. Why is it conducted? It is conducted to see if you are good enough to come and start working here as a doctor. And there are certain important things and a criteria for you to be called as a good doctor or a safe doctor who is good enough to start working here. We will discuss all these points one by one in a while. But can you take the Plab 2? As you know, that Plab 1 is conducted in many different parts of the world, but Plab 2 is only and only conducted in the UK. That's in Manchester. Earlier, there was only one center. That was Hardman Street. Now we've got Hardman Square and Hardman Street. So yeah, you've got two centers. If we talk about the exam itself, it is an OSCE exam, which is an objective structured clinical exam where you practically are sitting with a dummy patient. You will need to sit in, listen to that patient, and go through whole your consultation with that patient practically. About the different other many things, we'll talk about them one by one. So it is a practical exam. Practical doesn't mean that you only need to go in and do the procedures. Practical means that you will be practically sitting with the patient and doing a full-fledged consultation in 8 minutes, right? Right. So this is a very, very important area that we need to focus on at the moment. Plab 2 test dates. Unfortunately, Plab 2 dates has been a big problem for the candidates. Been looking for bookings. Many candidates, they tend to unfortunately cancel their dates, and those dates tend to appear in the system, and then you are able to book up on those days. So what is important here? What to do if you're not getting a date? Many candidates, they tend to adapt ways to get dates from third parties, which are neither you nor the GMC, which is considered completely illegal and a type of misconduct by GMC. I would highly advise you not to do that. If you talk about Plab 2 dates, I understand it's a bit frustrating and difficult because there are candidates who passed the exam who passed their Plab 1 about 2 years back. There are candidates looking for the dates who passed the exam just now. So there's a massive number of candidates looking for Plab 2 dates. Because of this frustration, if you're not able to get a date, you tend to move towards third parties where there are many Facebook groups, there are many illegal, misconductive WhatsApp groups. People tend to share their wrong links in the groups, trying to attract people to come in and book their Plab test with them. I would highly advise you never to think of doing that. Please do not do that. That is a big misconduct, and you are risking yourself. I do understand that you will come across many of your colleagues and friends who tell you that, well, I booked my exam with XYZ person, I booked my exam with XYZ agency, I booked my exam with XYZ company. Please do not do that. Don't take up those stories. Even if you think that's a very true story, keep in your mind that if it is a misconduct, it is a misconduct. You sometimes can fly away with telling a lie. You can sometimes fly away with doing something wrong to others, but please do not do this. This has been clearly told by the GMC as a misconduct. So Plab 2 dates, the test dates are there throughout the year. It is being run on all the months, from Monday till Saturday. Sometimes there are Fridays which are off, but anyhow, you'll be able to see all the test dates and days on the GMC website itself. Do not book your exam with anyone else except the GMC itself. So please be careful about that. It says that if you have a UK Plab offer or in the NHS that requires GMC registration or you hold a UK refugee status, in that case, you can directly contact GMC and they might offer you a date sooner. So that is a plus point. What does that mean? It means that GMC is very, very supportive. They want to support those who are able to quickly start working in the UK. These two things which have been mentioned here, they show that there's a doctor who has been offered a place, a job offer by a hospital, a trust-grade hospital in the UK. It means that you have been considered competent enough by that particular hospital that they have decided to offer you a job, and or you are a refugee seeking refuge in the UK from another country. In these two situations, there is a possibility, if you sit through your Plab 2 exam, you might quickly start working. So since the UK is in dire need of doctors at the moment, so what will happen is that if you write it to them, if they will have any date, they will definitely offer you at their earliest. How do you answer the questions in the Plab 2 exam? We'll go into the, let's go to the next picture first. All right, just skip this one at the moment. Can I book a Plab place through anyone else other than GMC? So this screenshot is the most important screenshot. It's the most important thing for you to know. Candidates can only book the Plab place through the GMC online account, and only the account holder must access the account. Very, very important. I very recently, about a week back, I got a message from one of my candidates who had taken the courses with me that he unfortunately got trapped with some person who said that he'll get him Plab 2 date, and he took the login and password, the ID of his GMC account, and he quickly changed his password and changed his email as well. So this person was not able to retrieve his email at all. Through his email, he was not able to retrieve his account, which is so very important for us to know. Please do not do that. It's a misconduct, and if you're caught into that trap, you won't be able to get any help from GMC. That candidate was helped out by the GMC because he had, I think, shared some details which actually were in a, he was in a situation that he could get his account retrieved. But if you go and tell send an email to GMC saying that I gave my login password details to a third party, and unfortunately that third party has changed my details, GMC is not going to help you out. Why would they help you? Because they have been warning you every now and then, please do not share your personal details with everyone. So please do not do that. Sharing your account details with a third party is a misconduct and may impact your Plab booking or any future registration application. Doing so can also put your personal, financial, and other online account information at risk. So please do not do that. Be aware of that. Be wary of that. Be wise when you do anything, when you take any steps at all. How do you answer questions in the Plab 2 exam? So now that is the main area which many candidates, many of you would be looking up to. How do we go? How is it going to happen? It looks scary. How am I going to face the patient? It's going to be a new sort of an exam, because back home you've been seeing patients who've been speaking your own language, who've been relatively easier to understand, and the hesitation of going and sitting in an English exam, on top of that, it can be itself a hesitation as well. Do not worry, really. It's quite an easy exam. You just need to remember that you should not be scripted. We will go into the details of being scripted and not scripted as well in a while, but it's very, very important for you not to be scripted. What do I exactly mean by scripted is that there are candidates who tend to have notes from different academies, and then they cram up those notes day and night, reading those notes to an extent. They read those notes, they cram those notes to an extent that they are not able to perform well in the exam, and they are quite scripted. They know information. They know the information from the notes which they are trying to apply to their patients in the exam, which makes them look scripted. And unfortunately, they tend to lose time, they tend to lose marks, and then they tend to lose the exam as well. After reading the instructions and the patient information outside each room, you will enter the exam cubicle and complete the task outlined. There will be a timer that announces when you move on. So let's have a look at this picture. It's not from a GMC exam, it's from a different exam, but this is exactly how you will be standing for the exam. The corridor is not going to be that thin at all. You will be quite at a wide distance from each other. Easier, you won't be that close at all. So there will be a distance of maybe 4 to 5 persons in between you. So this person will be standing and looking at his question outside the room. So this is the room he's going to enter. He's reading the question. He will take 1.5 minutes to read the question, and then he will answer the room, enter the room. Very important for us to understand, we are going to have, okay, before we go on to the details of this corridor, let's go into the details of how many stations you're going to have. You are going to have a total of 18 stations. 2 of them will be just the dummy stations where you're not going to come across any patient. Let's suppose, for example, room 2 and room 8, if they are your blank stations, there's no one inside. They are considered as rest stations. So you start from room 1, you go on to room 2, you go on to room 3. For example, if you reach your rest station, you will just sit there, spend some time. You might find a cup of water and a biscuit around just to relax your nerves, because GMC does consider that candidates do need some mental rest when they have already seen at least 7 to 8 patients, which is in real as well. When you're seeing patients, you do need some mental rest when you're coming across some consultations. So you do tend to have a cup of tea or a biscuit. So that is why you'll be coming across those 2 rest stations in your 18 stations. So in the nutshell, out of 18, there will be 16 stations where you will be meeting the patients, whereas there will be 2 stations considered as rest or dummy stations where you will not see any patients. So you'll stand in this corridor, you will read this question, you'll have 1.5 minutes to read this question, you'll have a bell somewhere around this corridor, which will be loud enough to be heard in all the rooms. Once you've read this question, whatever the question is, it can be anything, literally. It can be a medicine-related question, either due to gynae-obs, pediatrics, geriatrics, care of the elderly. It can be a counseling station, ethical stations. Very, very important for you to be ethical. So ethical stations, there can be lots of ethical stations in your exam. It can be an examination station, a procedural station, or it can be a Simmons station. We'll go into a bit of details of all these different types in a while. So once you read your question carefully, there's a technique to read the question as well. Once you've read that well, just go inside and then you start your consultation by greeting your patient, introducing yourself to the patient, and then going on with your consultation. You'll have 8 minutes to complete this consultation. You will be able to listen to your patient carefully. There are some interpersonal skills you will be able to exhibit, the way you are sitting with the patient, the way you are talking to the patient, the way you are listening to the patient, the way you are paying attention to your patient, your interpersonal skills. They are being assessed when you are sitting and talking to the patient and taking a good history, examination, doing an examination, and going on to the management. All right, so these are the different stations that we talked about, the different types of presentations that you can come across in the exam. Medicine, pediatrics, gynae-obs, care of the elderly, where you come across patients above the age of 65 years and have been diagnosed with any medical conditions, and or if there are some ethical issues around them, very, very commonly coming across such situations. You will have some counseling stations where your patient, let's suppose, wants something. So I'll go into a bit of detail of all these different types of stations. So let's start from the beginning. What can you get in a medicine station? You can have a patient coming in with chest pain, and or patient coming in with new onset cough, shortness of breath, and or patient coming in with gastrointestinal tract problems, GIT problems like diarrhea, vomiting, tummy pain, bloatedness, anything, literally anything. Then in pediatrics, you can come across different situations, like, for example, child with started feeling quite unwell quickly, child with a UTI symptoms, child with new onset cough, shortness of breath, and sometimes you can come across some safeguarding issues as well. Gyne-obs, you can come across lots of different presentations in gyne-obs. So all what you can see in your real life as a doctor when you are practicing as a doctor, trust grade doctor in a hospital, and or what you are seeing in the GP, you can literally come across anything in all these different settings. You can come across an older patient about 65 being brought in by their daughter or husband, or coming themselves for some sort of problems where you do have lots of things that you can do for them. You can come across counseling stations. For example, a patient coming in and asking, doctor, can I have some antibiotics for my child? So that can be a counseling station where you need to assess the child, take a good history, you need to examine the child, and then you need to be able to decide whether this child needs some antibiotics or not. So if, let's suppose, if the mother is asking for antibiotics or set of medications which you think that that person doesn't require, you need to counsel them. So those are the counseling stations where you are trying to justify the right type of management for the patient. You can come across ethics stations, lots of them, very, very importantly. And I'll tell you why you come across so many ethics stations. So problem colleague, where you are dealing with your colleagues, you can literally have many types of different problems when you are working as a doctor in the hospital and or in the GP with your colleagues, and you need to deal with those problems with good ethics in an ethical way. It should not be a very very dominant type of a talk. It should not be very very stressed type of a talk. So you should be able to know how you need to talk to a colleague when you're working in the NHS. And then angry patient, that's also a type of ethical presentation where the patient, you might come across a patient who is quite angry and upset for something that you might have done wrong, and or for something about the system, and or something about what your colleague has done wrong. So angry patient presentations can be very common in your exam as well. And then treatment refusal cases where the patients, they are in serious conditions, like, for example, coming across with pneumonia, with some sort of chest pains, and or coming with situations where they really need urgent management and treatment, but they are refusing treatment. And not only urgent, like, for example, patient refusing to take diabetes medications and or refusing to take his medications for hypertension. He just doesn't want to take it. That can be a treatment refusal case where you should be able to conduct that consultation in a safe way, where you are able to counsel the patient, take this medication, and if he is not counseled, then you are at least able to be a safe doctor in that consultation. We can talk about that later, how to be a safe doctor in all these different types of consultations. And breaking bad news can be another type of consultation you can come across, either on the phone or face-to-face. So these are different types of ethics presentations that you can come across. So you should be competent enough to be able to exhibit some good ethics, maintaining confidentiality of the patients, of your colleagues. That can be another type of an ethical issue that you can come across. So why do we come across so many ethical issues? Because good ethics is something that keeps you going, that keeps you in a good doctor-patient relationship, that keeps the system working. That is a lot of applaud if you have got good ethics. If you, it's very, very easy for anyone. Let's suppose, don't think about the exam at the moment. Just think about you yourself working as in a hospital, anywhere in your own home country. You come across a problem with your colleague, and you start shouting, or you become angry, or you become upset, and you go and tell your senior about it. It's just going to create a chaos and a mess for you yourself and for your colleague as well, which is actually a very, very wrong way of dealing with your colleagues. And then, for example, if you come across an angry patient who is shouting at you, and you start back shouting at him, and then there's a big fight and or a big sort of problem arising in the hospital or in the GP, that can be really chaotic for yourself and for everyone there in the surroundings, other patients, other colleagues, the staff members. So treatment refusal, very, very common. here, especially when you will start working in the Western countries? Why is it more common here as compared to our countries back home? Because here it is considered that if someone has got full mental capacity, then he has the right to refuse. Whereas back home, in most of our countries, the right to refuse isn't there. Unfortunately, the patients are being forced and pushed to do whatever either the doctor wants or the family wants. So that's the reason why these are all considered as ethical issues. We need to be able to exhibit very, very good ethics. We need to think about others before we say anything to them. We need to be able to calm ourselves down very, very well in order to go through that consultation in a good way. Just remember that whenever you talk to someone and it's an ethical issue, if you were able to come out of that situation in a very, very calm way, it means that you did well. If you created a chaos there in that situation, it means that you did unwell. Because whenever you do unwell, you have just hurt that relationship between a doctor and patient. So you need to be able to maintain that good relationship with doctor-patient, the good doctor-patient relationship. That's what keeps the system going. That's what keeps the trust between the two. So very important for us to know. Let's go to the next type of stations. That's the teaching station. So as this very activity that we're going through at the moment is a type of teaching activity as well. So I'm teaching you how you need to go through different situations when you'll be preparing for your Plab 2 exam, what you need to know. If you already know, how you can practically apply that knowledge. So it's teaching stations. Why do we get those teaching stations? Because teaching is a way, if you are teaching your colleagues, you are helping them develop. You are helping them move forward in their lives. If you are a good teacher, or if you are able to exhibit those skills in a good way, it means that you are somehow adding to the world, you are adding to the community, you are adding to the hospital, to your colleagues, to your profession. You are playing a good role if you're teaching. So you need to know some teaching skills when you'll be preparing for the Plab 2 exam. Like, for example, you should be able to know what the person exactly wants to learn, how you're going to teach him, to what extent you can teach him in this setting. Are you going to teach a lot, or just to the extent that he understands and grabs the idea of whatever you have taught and is able to go back home and recall all what you taught him? So it's really important for us to know how a teaching station would run in the exam. And then you can have some examination stations, Simmon procedure and prescription writing stations, which usually tend to become very, very stressful for candidates for some reason. Examination stations. Okay, so let me just tell you that out of your 16 stations in the Plab 2 exam, you will have 13 stations which will be from any one of these 4 or 5 areas. It can be medicine, pediatrics, gynae-obs, care of the elderly. It can be counseling, ethics, teaching, anything. So 13 stations out of those. You will have 1 Simmon station in your exam. Simmon station is the station where you will come across Simmon. Simmon is a dummy patient made of rubber, a big patient which is lying on the table. And usually a Simmon station is an emergency station where you are being assessed for your skills, how you would manage a patient who is in an emergency. The remaining stations are usually either potential emergencies, the ones that we talked on the top. They can be just a simple medicine station, non-emergency station, or a potential emergency station, whereas Simmons station is almost always an emergency station where you'll be in the A&E and you'll be dealing with the Simmons. You will be practically having some things around to show your skills, what you're going to do and how you're going to do practically. Examination stations and procedures. If you talk about those, if you guys are writing, it would be really helpful for you to remember later. So as we said, 13 stations from the top domains. You will have 1 Simmons station. So we made a total of 14. And you will have either 2 examination stations or 2 procedure stations, or you can have one examination and one procedure station, and or you can have one examination and one prescription writing station. So it can be a mix of all of them, but one Siemens station. Sometimes you may come across situations where the Siemens isn't working well, or the simulator is not present, so you may not come across Siemens station, but that happens very rarely. Usually you will be assessed over that capability as well. Yeah, so this is what we're talking about, different types of consultations. So it's really important for us to understand what type of settings can you be in when you are going through either it can be a telephonic consultation, or it can be a video consultation, or it can be face-to-face consultations. Face-to-face consultations, as we just talked about, it can be face-to-face consultation, including all the different domains that we discussed earlier, and including the examination, practical procedure, and your Siemens stations as well. So it's important for us to understand that when you go into the exam, do not forget to look at the top line of your question paper. The question paper on the top always starts with, you are in FY2 working in the pediatrics department of NHS hospital, and or you are FY2 working in the geriatrics department, and or you are FY2 working in the respiratory department, in the cardiology. You are a GP working in the general practice. It's very important for us to know where we are. Sometimes candidates tend to ignore that part of the consultation, which I consider as the most important, because let's suppose if you are working in the GP and you come across a patient who's got MI, let's suppose, and he's having central chest pain radiating to the left shoulder, associated with nausea, vomiting, crushing in nature, 8 out of 10, and he has been having this pain for about more than 30 minutes, is perspiring, has got nausea, vomiting associated, and you're thinking that this could be MI, and you tell the patient that, okay, we will keep you here. So now listen to this carefully. So this patient has come to you in the GP, and you tell him that, okay, we will keep you here, we will give you some medications, and we might need to do some procedures and or some tests to see what is going on. So if you say all that, now you're giving the impression to the patient that you are going to keep him in the GP, because you did not read the question carefully. You thought that you are in the hospital, whereas you are actually in the GP. You are thinking in your mind that you are in the hospital because you did not read the question carefully. So if you are in the GP, you actually need to send this patient to the hospital immediately. So you need to tell him that, well, it's an emergency situation, Mr. X. We need to look into that carefully, and we need to send you to the hospital immediately by arranging an ambulance. If you haven't read your question carefully, you can easily miss that information, and you can easily mislead yourself into the consultation by keeping the patient in the GP, which will mark you down in the exam. So do read that very carefully. So what I was trying to tell you is that the consultations can be at different places. They can be in different departments of the hospital. They can be in the GP. They can be anywhere, like in the ED. It can be in the gum clinic. So these are really important areas to think about when you are reading your question, because you need to know exactly where you are. You know that when you're working in this general practice, even if you're back home, you've got a different mindset. You have a relatively calmer mindset, whereas if you're working in the hospital, you've got a different mindset. You've got a lot of people around, a lot of support around, your consultants around, your colleagues around, so you can work as a part of a team, a more wider, bigger team when you are in the hospital as compared to what you can do in the GP. So it's really important for us to know where we are. Right, coming to the most important part of what you need to know about the exam. What will you need to demonstrate to pass? You actually need to know how to follow the structure, how to take a good medical history, how to be a holistic doctor who is able to holistically care for the patients. We'll talk about that. What does holistic care mean? And then whether you can be a safe doctor when you're doing, when you're history taking, when you're doing the management, when you're doing examination of the patient. So all these different areas of the of the consultation, they need to be able to exhibit. You need to be able to exhibit that you are a safe doctor. So some part of your history would be able to guide you to whether it's a safe consultation or not, in terms that, for example, you need to ask some questions to every patient coming to you, some problems, to rule out the red flags in that particular consultation. So when you take history in a way that you rule out red flags to become a safe doctor. So that is a safe history, basically. And then you go on to ask the lifestyle of the patient, identify patient's ideas, concerns, and expectations, which are really very, very important. So let's start from the beginning a little bit. Let me give you a small example. If you just keep looking at this very presentation, which is there on the screen, this very slide that is there on the screen. So let's suppose, for example, as we were just taking the example of a patient coming with chest pain, how you will be able to exhibit all these different things into that consultation, and what you need to think of skipping in certain situations, and what you always need to ask in certain situations. So let's start from the beginning. A patient has come to you who is, let's suppose, 65 years old. Mr. X has come to you with a chest pain, and you are coming across that situation in the hospital. You are there working in the emergency department. So you need to take an appropriate history. So as the top line says, initial appropriate history of presenting complaint. So you will always start by taking the history. Can you tell me more about this pain? When did it start? Does it go anywhere? What type of pain is it? What were you doing when it started? Is there anything that makes it better or worse? Or on a scale of 1 to 10, 1 being the lowest pain, 10 being the highest pain, how do you grade your pain? So you need to be able to take a good initial pain history, and then you can go on to rule out some differentials. Differentials for a patient who is 65 years old coming to you with a chest pain. There could be really important differentials depending on what you got from your initial pain history. There are some mnemonics for the pain history. You will come across all those mnemonics one by one when you'll be, like, for example, coming. Okay, we'll discuss the mnemonics later. So you take a pain history, you rule out your differentials, like, for example, pneumothorax, pulmonary embolism, aortic dissection. You rule out pneumonia. You ask all those questions, and then you go on to take the medical history from the patient. Medical history is almost always important, because if this patient already has a background history of, when you ask this patient, have you been diagnosed with any medical conditions in the past? And the patient tells you that I've been already diagnosed with an ischemic heart disease. It's going to help you identify the fact that this patient is definitely having an MI. Or even if he says nothing at all, you still need to consider that as MI. If the patient is giving you a typical chest pain MI history, central crushing chest pain going to the left shoulder, XYZ, things like that. So taking an appropriate initial history and then going on to the differentials and taking the medical history, going on to ask the patient what medications he's taking at the moment is important, because you might be planning to give some medications to this patient. So if you are planning to give any medications to the patient might already be using some medications. Let's suppose, for example, the 61 years old man, just imagine 65 years old man coming to you with a chest pain, ischemic heart disease, might be using sildenafil for erectile dysfunction, where sildenafil can interact with GTN. So you really need to know what the patient is already taking. If the patient is taking any such medications which you need to be beware of or be careful about, then you need to skip that particular medication if you need to. So it's important to ask what medications the patient is already taking, and if he has any allergies, very important. So medical conditions, medications. So this part of Meftosa, which I've just put in there to help you a bit, medical conditions, medications, allergies. So now coming on to family history, travel history, occupation, and then social history. Some candidates tend to ask each and every question from Meftosa, the initial structure where you're taking the, excuse me, please. Yeah, excuse me for that. Thank you. Just a bit of bout of cough due to speaking continuously. Right. So coming back to Maftosa. So just remember that this is a very, very important take-home message today, which many candidates tend to make a mistake on. Patient sitting in front of you with a severe central crushing chest pain, radiating to the left shoulder, associated with nausea, vomiting, sweating, and all that. This patient is having an MI. Come on. Please do not ask him, have you traveled anywhere recently? Do not ask him, what do you do for a living? Do you have any stress at work? Do you smoke? Do you drink alcohol? You need to first manage his chest pain. He's having an MI. He can collapse in front of you anytime. So what's the most important for you is to try to move on to important questions only, and then you go on to your management for this patient first. So ask a superficial, relevant, appropriate short history, depending on what you need from this particular history. Skip lifestyle history in this patient because you are least worried about lifestyle at this point in time, where he has got typical features of MI, because you're not going to be managing his smoking or alcohol or diet or exercise or his stress at this point in time. You can do that later. That can be done later in the GP. If he is dying of an MI, try to save his life first. So that should be a priority. If he doesn't have typical MI symptoms in this chest pain case, that definitely, if you're thinking it's just an angina where the patient is not in pain at present, patient is quite calm, sitting in front of you, in that situation, yes, go ahead. Ask all the lifestyle questions, because you need to know that whether he smokes or not, you need to know whether he drinks alcohol or not, because you can then work on his lifestyle to prevent progression of his disease and prevent further angina attacks and stuff. So it's really important for us to know when to ask lifestyle history and when not. Emergency situations, always try to skip on that. So it was just a short type of a guide to how you need to approach your cases, because since you are starting your journey for Plab 2, you will come across people who are guiding you to ask everything in Maftosa, which is quite senseless and not going to be good if you are dealing with an emergency situation, because it's important for you to go on to the management as soon as possible. All right, so let's suppose you've already done the medical history, the appropriate lifestyle history, either needed or not needed. You go on to your next step in the history, the end of the history. You can always ask about ideas, concerns, and expectations. What is ideas, concerns, and expectations, and why is it so important? This is the most patient-centered thing, in my opinion, when you ask these things to the patient. Because let's suppose if you've got this patient sitting in front of you and his idea about this chest pain is different than yours, then you need to be able to justify yourself. So in order to justify yourself, you need to know his idea. If you don't know his idea, you really can't read what's going on in his mind. Let's suppose if he says that, when you ask him, have you had any thoughts about what could be the cause of this chest pain? And if he says, doctor, I think it's just it could be just a heartburn. Maybe I'm having some reflux because I've too suffered from reflux in the past as well. Here you need to clarify or justify your idea and tell him that, well, I understand that you thought that it could be a reflux, but I'm a bit concerned. It looks like a heart attack. So you need to know his idea in order to be able to clarify what you are thinking about the situation. And then concerns, very, very, very important. If they're concerned, if someone having an idea, this could be reflux, at the same time, he can have a different concern as well. He might be worried about a heart attack, but he thinks that he has got a reflux. So candidates tend to get confused between ideas and concerns. They think that they are the same. They're not quite the same. They're quite different, I would say. So always ask about concerns. If the patient is concerned about anything at all, you can go on from there. Let's suppose if the patient says that, doctor, I'm worried about a heart attack because my mom also died from a heart attack, or my dad also died from a heart attack. Well, Mr. X, sometimes patients coming with a pain like yours, they do tend to have heart attacks, unfortunately. We'll look into that in a while. And then you go on with your you'll go on with your remaining consultation and ask the expectations, and then go to relevant examination. When it comes to examination, in the Plab 2 exam, you do not have to practically perform examination in every station. As we talked about earlier, let me go back a slide, previous slide. As I told you that you will have examination, you will have, just a second, yeah, this slide. And I told you will have 13 out of these consultations. You will have 1 Simmons station. You will have either 2 examination stations or 2 procedures, or 1 examination and 1 procedure station. We'll discuss about what type of examinations you can come across and what type of procedures you can come across in a while. So if you have this MI patient, let's suppose, you may not be expected to do an examination for him, but you are definitely expected to say all the examination that you would like to do in a patient coming to you with a chest pain. So let's suppose Mr. X is sitting in front of you and you want to do an examination. You tell him that, well, Mr. X, I would like to do a quick examination on you, including checking your observations, listening to your heart and your lungs. So you are simplifying your respiratory and cardiac examination by saying that I'll quickly listen to your lung and heart, and I'll quickly do a heart tracing for you. Is that okay? So you always tend to, it's ethics. This is also good ethics, asking the patient's permission, making this consultation patient-centered is very, very important. So it's not that just like back home in many countries, we tend to just lay the patient down. Okay, just lie down. I need to do an examination on you and I need to listen to your chest. Doctors don't even tend to sometimes mention all that examination, and they don't tend to take permission. Whereas when you're working in the UK, you'll need to do that. It's just a small line where you are taking permission from the patient. So you always need to say that, well, Mr. X, I would like to do a quick examination on you, including checking your observations, listening to your lung and heart. I'd like to do a heart tracing for you. Is that okay? Yes, doctor, that's fine. Your patient can always answer you that. No patient wants, if he has come to you, obviously he'll be happy with the examination as well. Usually no one will ever stop you from doing that. So do take permission, and then you're going to make a diagnosis and do the management. Whenever you do an examination, as I said earlier, we talked about history, that your history should be a safe history. So you should be able to rule out all red flags while taking your history. You should be able to rule out your red flags in the examination. What do I mean by ruling out red flags in the examination? For example, you took a history from the patient. The patient was, let's suppose, 40, 45 years old, coming to you with a heartburn and coming to you with a chest pain associated with heartburn. You took a detailed history from the patient and you think that this looks like a reflux, but still you would like to listen to his chest and you would like to do a heart tracing for him because he's 45. He's reaching a stage where patients do tend to start suffering heart problems. So you might want to do an ECG for him to make sure that there's nothing serious. Depending on the age, depending on the background, depending on the family history, depending on the situation, you might need to do a bit safe examination for this patient here. So just be mindful of that. You always need to be a safe doctor when taking history, doing an examination, or making a diagnosis and management. For the sake of diagnosis, we can't always be 100% about the diagnosis. It can be a bit challenging for different doctors because everyone coming to the UK can be at a different stage of their preparation, a different stage of their experience, a different stage of their practice with their colleagues. So it's really important for us to know that since everyone can be at different stage of their preparation, it's not appropriate even to think that everyone can make a similar diagnosis or can make a diagnosis quite quickly. It can be a bit of problem for many candidates to make diagnosis if they haven't come across those situations in their life, and they're coming across such a situation. Let's suppose, for example, anything like, for example, patient coming to you with ear pain, or patient coming to you with a painful red eye, which is a red flag itself. You may not know that it's a painful red eye is a red flag, and you are a bit caught there. for the sake of exam, I would definitely advise you to go through as much study materials according to the GMC guidelines as you can. So you should be able to pick up some important red flags and important diagnosis in your consultations to show some competence in the exam. But the important thing here is that if you come across a situation where you took a detailed history, but you were not able to make a diagnosis on the basis of your history and examination, you are not sure what's going on with the patient. What would you do in that situation? Do not get frustrated. Please do not try to say a diagnosis always. The purpose of this exam is not to be able to make a diagnosis 100%. The main purpose of this exam is to be a safe doctor. Having said that, I do not mean that if you don't make a diagnosis, it's fine. No, I do not mean that at all. What I mean is that if you do come across a situation where you're not able to make a diagnosis, please be very clear and honest with your patients. You need to be able to say that, well, Mr. X, I did ask you a few questions to know what's going on, and I did an examination on you as well. I'm a bit confused. I'm not really sure exactly what's going on. The cause of your symptoms, there could be many reasons as a cause of your symptoms, but I'm not sure exactly what's going on. So I need to look into that. Is it okay if I can check with my senior or my colleague here in the GP, and then we can go on from there? So in order to be a safe doctor, you can always work as a part of a team. You can always involve your colleagues. You can always check your guidelines. You can always check your CKS guidelines. You can check patient.info if you want to share something with the patient. So in order to be a safe doctor, it doesn't require you to always make 100% diagnosis in 8 minutes, not at all. You can't always make a diagnosis in 8 minutes. In that situation, you need to learn how to be a safe doctor. Learning to be a safe doctor is very important. Let me give you a small example here, which I often give to my candidates who are in the course with me. Let's suppose a patient is coming to you with some sort of a tiredness, and this patient has been feeling tired for a few months, and you're taking history. When you took his history, you found out the positive findings in his history were that he has been sleeping a lot, he has gained some weight, he's snoring at night, and he has got lack of concentration and stuff like that. And now you are a bit confused. You're not sure whether could that be an OSA presentation, obstructive sleep apnea, or could that be a hypothyroidism? You're not sure exactly what that is. In that situation, you can always tell your patient, well, Mr. X, see, there can be many causes of this tiredness. And in your case, I'm not sure what's exactly going on. It looks like you could have a couple of reasons for your tiredness. It could be something called as an OSA, which is obstructive sleep apnea, and patients tend to present with similar symptoms as you have: snoring, tiredness, lack of concentration, XYZ things, and weight gain as well. And similarly, if someone has got hypothyroidism, they can come up with weight gain and excessive sleepiness and tiredness as well. So we need to run some investigations. I can involve my senior. We can look into it, what's going on, and we can go on from there. Is that okay with you? The patient will say, yes, doctor, that's fine. Of course, the patient is not expecting you to be a magician to be able to say the diagnosis exactly from the very beginning of your consultation. So the first 8 minutes of your consultation, you just need to be a safe doctor. That's the most important thing. Conduct the consultation fluently and professionally. So that's an overall assessment of what you're doing. You should be able to do that fluently and professionally. That's why, as I said earlier, try to practice with your colleagues in English language, practicing in your own language, either Urdu, Hindi, Punjabi, Arabic, Spanish, Persian, whatsoever. It may not be very helpful in making you do a fluent and professional consultation. No, I wouldn't say professional. You can still be very, very professional when you're practicing in your own language, but the fluency might lag a bit. So I would highly suggest you to practice in the right way, in the right direction. Be a safe doctor whenever you are doing so, when you're doing the consultation. What will a scenario look like? So Now, we've already discussed quite in detail what you need to do in an exam. What will a scenario look like? You are in a mock consultation with a patient played by a role player who has been briefed about this condition. So what does it mean? You are sitting in a room. Let's go back. You're sitting in a room. That's the patient sitting in front of you. You're the doctor. You have already read the scenario outside, and you're sitting with the patient, and you start taking history from this patient, as we discussed all these different history points in there, the ideas, concerns, expectations, doing an examination, and then doing a management. So you are in a mock consultation with a patient played by a role player. Important for you to know. The consultation that you're doing is with a role player. It's not the real patient, it's a role player. But at the same time, you need to remember that when you are doing the consultation, you should be able to do the consultation in a way that you should be acting like a doctor. Don't take that easy, don't take that lenient. It is an easy exam, there is no doubt about that, but some candidates tend to lack the idea about what exactly the exam is. So the patient sitting in front of you is a role player, but he will only say yes or no to the questions he has been briefed about that condition. So this statement is from the GMC website itself. It's not my personal statement at all. You are in a mock consultation with a patient played by a role player who has been briefed about their condition. So the patient has been told that, Mr. X, when the doctor will be sitting in front of you and will be asking you questions, you need to say yes to this question and you need to say no to this type of a question, and they will be literally acting like real patients, so you need to literally act like real doctors as well. What will the examiner be looking for in you? As we already discussed these few areas, the same areas you are going to be assessed for in the exam. So data gathering, technical and assessment skills, clinical management skills, and interpersonal skills. So if we divide your 8 minutes time in the exam, it can be divided into 2 parts. You do not need a separate time period for your interpersonal skills. Thank God. So one thing is out. I'll tell you how you need to go about the interpersonal skills. But if we talk about the time management, you can divide your 8 minutes into 2 parts. Best would be to do your data gathering in the first 5 minutes and then keep at least 3 minutes for your clinical management skills. You will not be having any clock inside the clock. You will not be allowed to wear a watch inside your exam, but you will be able to hear the bell, because when you are in a real consultation with the patient, you're not checking the time all the time, looking at the time. So it should just be a rough idea. You should be capable enough to be able to take a history and gather all the data from history and examination within 5 to 5.5 minutes. So it should be your practice which should make you perfect in doing that. So you will not be having any clock inside. You will not be able to see your watch because that will be outside. If you're wearing a watch, you'll be asked to remove that. So it's just a rough idea of time that you need to have. You need to have your structure firmly in your mind to be able to take good advantage of that time. At 6 minutes, you will be given a reminder bell. You will be able to hear a bell outside in the corridor. 2 minutes remaining. So this bell is going to tell you you're left with 2 minutes only now. It's time to come to the management, Mr. Dr. X, as soon as you can. So let's suppose if a candidate is taking history and he has already reached the 6 minutes and he is still not finished his history, it's really important that that bell reminder should be able to remind him, come on, move to the management now, it's time, it's getting late, because you need to be able to, a safe doctor, you can't just take history in 8 minutes, you need to be able to do the management as well. So do your management in the next 2 to 3 minutes that you have. There are structures for different types of presentations coming to you. Going back a little bit, let's suppose we talked about medicine, pediatrics, gynae-obs, COTI, we talked about counseling ethics. So every type of presentation has its own structure. Roughly, let's talk about pediatrics. The structure for pediatrics is, the structure for medicine is the one that we just discussed, the Maftosa. The structure for pediatrics is The structure that I teach is BINDSMAF, PINDSMMAF, which is birth, immunization, nutrition, development, and then the social history of the child, and then medical conditions, medication, and allergies if the patient has been diagnosed with any. So the structures are very, very important. If you know the structures well, you are able to go in, take initial history, and apply that particular structure in the consultation very quickly and easily. If you don't know the structure, you'll be quite lost in the exam situation, not knowing what to do and what not to do. Similarly, gynae has its own structure. Some people tend to do 4Ps structure for gynae, others tend to do 6Ps. I tend to go into a bit more detail depending on whatever the situation is, asking about their periods, partner, pills, pregnancy, pap smear, and prevention of cancer with Gardasil vaccination. So depending on whatever the age of the patient is and whatever the presentation of the patient is, you can always apply your structures to different type of presentations. And then counseling and ethics, you do not need to always go through the medicine structure of MAPTOSA. It depends on the situation, the setting where you are and what you're doing. So it's really important for us to know what the different structures are. And going on to going back to this part, what will the examiner be looking for? The examiner wants to see you demonstrating the behaviors that we expect of a doctor. Very, very important. They will mark you against these 3 domains: data gathering, technical assessment skills, clinical management skill, and interpersonal skills. As we've already discussed, you will be marked against these 3 areas. The time can be divided into data gathering and clinical management skills, whereas the interpersonal skills, they are the skills which are being assessed throughout your consultation. The way you enter the consultation, the way you greet the patient, if you are actively listening to the patient, what's your body language about with the patient? Are you, let's suppose, for example, if you are in the exam situation, let's take a good and a bad example of interpersonal skills in an exam situation. Some people tend to think that speaking a lot of English language sentences in the exam is something called as communication on interpersonal skills. No, please, that is not interpersonal skills at all. Some candidates tend to think that whenever a patient is answering us, we need to speak a sentence in response to that always. Like, for example, if the patient is saying that, doctor, I've got chest pain. Oh my God, you've got chest pain. Oh, I'm so sorry to hear about that. How are you coping with that? Some people tend to think that this is interpersonal skills. I'm really sorry to tell you, this is not interpersonal skills. Interpersonal skills is something very, very simple. Interpersonal skills mean how you can be ethical with a patient when you are doing a consultation. What do you yourself think of an ethical doctor? When you go to see a doctor, even doctors get sick. They tend to see doctors. They tend to go to the hospital. They do tend to say they see their GPs regularly. So when you see your doctor, how do you feel when you come across a doctor who is not having some good interpersonal skills? So as I said, I'll give you an example of bad and good interpersonal skills. I'll first give you an example of bad interpersonal skills. It's a real example that I came across myself about 2 weeks back when I went to see my dentist. I went in to see my dentist. I was having quite a bad facial and right-sided upper dental pain, and I had to go through certain scans, and ultimately was diagnosed to be a tooth carie that was developing from somewhere unseen part of my tooth. When I went in there, I was in quite a lot of pain. My doctor knew that I'm a doctor myself, but despite that, he did not really pay much attention to what I was saying. I had many questions in my mind to ask my doctor, but he was least interested in answering my questions. When I went in there, he said, oh, okay, so I can see that you've come in with some dental pain. All right. So I think that's be fine. Let me just quickly do an x-ray. He didn't take much history from me. I was not happy. I was not satisfied. I had a lot of things in my mind to tell him. I had a few concerns as well, and a few of my ideas as well. He did not ask me my ideas and my concerns at all. I was not really, just a moment, Dr. Yahya. Can you please calm down? I'll definitely listen to all your questions at the end of this session. Do not raise your hands again and again. So I came across that situation and I really did not feel happy, and I had to just, let me just get rid of this thing. So what I had to do was that I had to end up taking private consultation from a different doctor. I was not happy with that, with the ethics of this patient, of this doctor. I was not happy with his interpersonal skills at all. So that's all what I did. What happened as a result? I mean, the doctor-patient relationship ended over there, isn't it? That ended completely. We will never see each other again because I don't want to see him. So I went to a different doctor for taking his second opinion about what I have, though I booked that consultation privately. And during that consultation, this doctor was really, really nice. He did ask me very good history questions. He did ask me, he was head nodding, he was with me. I could feel his presence with me. He was looking into my eyes. He was being very empathetic during the consultation. And he did ask me if I've got any concerns or any, I was having lots of concerns, actually, lots of questions, because it was the first time I ever had any dental pain. So I had a lot of questions about it. So he did answer all my questions. He gave me enough time. And that's how we ended up the consultation. So that's an example of good and bad consultation, where you can either maintain or you can just completely end up your doctor-patient relationship with good or bad ethical skills or good or bad consultation or interpersonal skills. So it's really important for us to be able to exhibit good interpersonal skills in the exam, because that can end up or can lead to a long-lasting relationship with your patients. So good interpersonal skills include, for example, greeting your patient in a nice way, showing good body language when you're talking to the patient, like, for example, head nodding, moving your hands a little bit if you need to, not always, obviously only if you need to, while explaining situations and stuff, pointing out at things. For example, if you're giving an example of an ear, you can point out at your own ear, or whatever you want to, whatever you think can be the best way for you to exhibit your interpersonal skills. And then listening to your patients very carefully, very important, because sometimes candidates do not listen to the patients carefully, and what happens is that they end up asking the same information in the form of questions again and again and again, because they were not listening carefully. And the patient might feel a bit annoyed that, why is this doctor asking me again and again, how long has this pain going on for? I told him 3 times and he still doesn't know that it's going on for an hour now. So it's really important for us to listen very carefully. Yeah, asking your ideas, concerns, expectations is very important. When it comes to the management part, what is the most important part of your IPS in the management? So certain things in the history and certain things in the management can be considered as good IPS. In the management part, when you're doing the management, taking the patient's checking the patient's understanding. Is that clear, Mr. X? Are you happy for me to go on? If you've got any questions, please feel free to ask me. Things like that can be very, very good interpersonal skills, and they are showing a very good patient-centered approach as well. If you just keep quiet and just tell your patient, well, Mr. X, you seem to be having this dizziness due to this reason, and I need to give you some medications. We'll start you on the medications now, because you're in your mind, you are in a rush, you want to finish everything in 2 minutes, and you just did a one-sided consultation and you just tell everything to the patient and you're not involving him in the management at all. This is what will lead to a failure in the exam, because you are expected to be expected to be patient-centered and not doctor-centered at all in the exam. So do take into account the preferences, the ideas, concerns, expectations of the patients when you're doing the consultation. So very important part of your consultation. You do not need separate time for showing interpersonal skills. It's an overall part of your whole consultation, which starts from your entry into the consultation and you exit when you leave the consultation. Thank your patient when you leave the consultation. See you again. See you later. Say things like that, and then you leave the room. What could be the few best resources when you are preparing for the Plab 2 exam? Good medical practice guidelines, blueprint for candidates. It is on the GMC website. You can get that blueprint from the website, and if you just type in Google blueprint for candidates GMC, you will be able to reach a point where you can see a link. You might need to scroll through a few things, and then you'll be able to see. So all the important topics that you need to be able to know about for the exam, they are there. NHS website is a good resource for patients actually. Sometimes even doctors tend to quickly scroll through that and see what we need to tell the patients, and CKS guidelines, very, very, very important for you to go through them for the management. You do not have to do all the management that is written in the CKS guidelines, because what I exactly mean is that CKS guidelines is the best resource for you to do the management, but some candidates tend to just think that, okay, we have to do 100% each and everything from CKS guidelines. But you can't do all that in 2 minutes time. So you need to be able to pick up the important things that you need to talk about in your 2 minutes. So you need to know, okay, Mr. X, I'll give you some antibiotics and I'll follow you up in this much time. And to be a safe doctor, you tell him the red flags. So you need to superficially know your CKS guidelines management for each and every of your station in the exam. And then Geeky Medics, it's a very good, very, very good resource of examinations and procedures. You do not need to go here and there. There are some good NHS websites as well. As soon as I get some time, I'll definitely look into that and share all of them on my page. Just beware that PNF is the ultimate guide and micro guide is the ultimate guide for you when you come across situations when you'll be working in the NHS. BNF is very, very, very important. You do not need to cram BNF at all. That's another misconception. Candidates who come across their prescription stations in the exam, they think that they need to learn the doses. They need to know each and every dose on their fingertips. That is the biggest mistake that you'd be ever thinking of. No one can learn the doses. No one can know exactly what dose needs to be given in what situation. If you will try to do that, and if you will try to apply that knowledge for your patients, believe me, you will be the most unsafe doctor. So you're not expected to have the BNF crammed up, even for the common situations. Yes, it's good to know the common doses, common medications, but you're not expected to do that at all. That's the reason why in the prescription station, you will already be given all the doses and the medications names, their units, their frequency, with what frequency they need to be given. For example, you need to write the paracetamol for this patient, which needs to be given 1 gram QDS, IV or per oral. So you are given everything in there. So you don't need to open your BNF for that, because all that information has been given from the BNF. So for your prescription stations, literally they are the easiest stations. I am going to very soon conduct a session on the prescription stations as well, and that is when I'll be able to in more detail guide you about why you do not need to worry about it at all, because you've got your BNF for support whenever you are not sure of any medication or any prescription that you need to write about. In the exam, the question will be given that your consultant, your XYZ consultant in the XYZ department has advised you to write XYZ medications for this patient in the prescription chart. Go in and write these medications for the patient. So all the medications names, their doses, their units, their frequency, their timing, everything would be given in there in the question itself. Sometimes, very rarely, just to test you whether you know how to use a BNF or not, you might be given one medication without a dose and or with incomplete information or without units, something like that, where you can be required to open your BNF. So just be mindful, do not make any mistakes, and do not take any misconceptions back home when you're doing all that. Very important question that which I come across from the candidates very, very frequently. Dr. Nu, how long do we need to prepare for this exam? It really depends on, do we need 1, 3, 6 months, 1 year, 2 years? Believe me, there are candidates, unfortunately, who have even prepared for 2 years, but they couldn't go through the exam even on their 3rd attempts, and sometimes they have to just quit after giving the fourth attempt, and then they have to go through all that cycle of going through OET, Plab 1 and Plab 2 again. That happens very rarely. I do not mean to scare you guys at all, but what I'm trying to tell you is that the duration of preparation really depends on your previous knowledge, how much you have learned from your Plab 1 exam. Your previous experience of working as a doctor practically really matters a lot. And if you've been doing good medical practice, that is amazing. That is excellent. If you've got good knowledge and you've got good previous experience and you know a bit about the structures as well, believe me, there's a high chance you can pass this exam in 1 month. You just need to know the appropriate structure for each type of a presentation or situation. If you are somewhere, maybe a recent graduate who has recently graduated about a couple of months back, just done with your internship a couple of months back or 6 months back or a year back, you've got very high chances of passing the exam. But again, it might take about 3 to 6 months. I would always advise the new and fresh graduates to know, to learn much more as compared to the old graduates, because they have less experience. So you need to be able to practice, and you've seen less patients in your life as compared to the doctors who have got more experience and have seen more patients. So practically, your knowledge and your experience matters a lot in deciding what duration of preparation you need. But you can always decide that by getting yourself assessed or by practicing with others, putting on a timer. There are hundreds of candidates who never took any course, who never took any workshops, who never went through anything at all, but they amazingly passed the exam in the first go. They never had to do anything at all. They just read the guidelines and they went through the exam. It's a rarity to happen, but yes, people with knowledge and experience and who have already been through different entrance exams, they do tend to pass exams really easily. A perfect consultation needs a patient-centered approach. Very, very important. We've already discussed this earlier, so I will not go into the details of this now. An appropriate history, a relevant and safe examination, a complete management for the patient, and a safe management. Again, complete management does not mean that you have to cram the CKS guidelines and say them word by word. Of course not. There are candidates who tend to struggle and stress out a lot with that. Because let's suppose if you open up the management of migraines, you will have one full-fledged long sheet and you don't have to say everything. You just need to be able to diagnose that condition, able to say that condition and justify why you're saying that it looks like a migraine, and then you still be a safe doctor, give red flags to your patient, give a good management to the patient, follow up your patients when needed, give prophylactic management if you need. So you can just say one sentence about each component of that particular part of your management, and then you can go on with that. That would be amazing. Interpersonal skills, we already talked about that. That is something you need to exhibit throughout your consultation. Ideas, concerns, expectations, important in each and every situation in the exam. What are the common causes of, let's go through this one first. So the marking scheme is such that your history is going to have 4 marks, your management is going to have 4 marks, and your IPS is going to have 4 marks. Going back to the number of stations again, you will be going into total 18 stations. 2 of them will be rest stations. Remaining 16 stations would be a mix of all the different type of presentations that we talked about. In each and every presentation, you will be assessed like that by taking history, management, and your IPS throughout your consultation. What can be the common causes of failure in the exam? Taking a very, very long history, taking history for about 7 minutes, 8 minutes, something like that. Definitely, it shows that you are not on track. You don't know what you're asking. You're just trying to ask each and everything in the whole human body. You're starting from head and you're ending on toe. You are not even going to end your history in 8 minutes. So please do not do that. It should be a relevant, precise, good, nice, juicy history where you have ruled out your red flags in the history itself. Poor interpersonal skills. As we already discussed, I ended up my relationship with my dentist just because of his poor interpersonal skills. I did not feel satisfied. So interpersonal skills are important. We've already discussed the different components of your IPS. Incomplete or wrong management. So if you are doing the management, as I said earlier, every doctor is at a different stage of his life. Some of you might be just very fresh graduates. Others might have practiced 20 years of their life and now they plan to move to the UK. Everyone has got a different set of experience as well. So if there is someone who has got less experience in life, He knows what are all the differentials of headache, but he doesn't know how to rule them out. And at the end of his history, he ends up thinking about 2 to 3 different things, and he doesn't know exactly what that is. He can always still be a safe doctor by saying that, well, I'm not sure what's going on with you. And he can still manage this patient in a safe way by saying that I'll involve my senior, and we need to run some investigations and see what it is. And we might need to send you to the hospital, depending on if you've come across some red flags. So it's really important for you to have your good medical knowledge. But if you still come across a situation, despite having an excellent medical knowledge, you are a bit confused in the situation, please do not panic. You can still be a very, very, very safe doctor. So doctor-centered consultation, very important. We already talked about. These are a few words that I want you to be wary of, because when I take mocks, I do come across different types of people, different types of the consultation, doctors performing in their own different ways. Saying I will, you should means that you just want to know what you want to know, and you're just forcing the patient what he should do. I will give you this and you should do that. I will give you this and you should do that. I will give you this medication and you should take that medication. I will give you these leaflets and you should read those leaflets. Whatever. Don't use these words. Be humble, kind, and nice. Share your management plans with your patient when you're doing the management. Try to avoid these 2 words when you're doing your management. Very important. So we're done with today's session. I really hope it was helpful. I understand that it can be a bit confusing and chaotic for the candidates starting their Plab 2 journey, but I just try to simplify the things so that you guys can to some extent benefit and have a basic structure or basic knowledge about what Plab 2 is, and then you can go on from there. We did discuss about the exam booking, so just be very, very careful about that. I do not want any one of you to suffer by giving your personal details to anyone at all, because there are people, there are unfortunately unethically who are sharing details, wrong details with the candidates, taking their exam IDs, their email IDs and everything, and then changing their IDs, and then candidates are suffering, going through a lot of stress because of this booking as well. I think even if you don't have a date, waiting is always the best. That is another type of ethical skill that you will be able to put in yourself. Showing some good ethics and avoiding any type of misconduct is really very, very, very important. Just be mindful of all that. Thank you very much, everyone, for attending. I will just, in a second, open the session for any question answers. Just give me a minute for that, please. Thank you very much for your cooperation.